I wanted to start by saying that it's fun for me to be here, and actually I have to say I'm really kind of overwhelmed with how far this organization has come in the last, it's only been 6 years, I guess. It's because of you and your passion for what I think the organization is trying to do, and it's good to see. And I have to say that also that, you know, I'm a science type, and when I first became involved with this organization, my perspective, I'm also a nephrologist taking care of adult patients with glomerular disease, but my perspective was primarily that of the scientist, and feeling frustrated that the NIH and other organizations, particularly the larger kidney organizations, seem to me to be spending more time worrying about the patients that had already reached end-stage kidney disease, who were already on dialysis or needing transplantation, and weren't investing more in preventing disease in the first place. And I think that perspective has changed over the last few years, but not in the larger kidney organizations. And so I think it's very important that organizations like this exist and that you continue to push your cause. I think it's really valuable because I think ultimately you're going to make a really big difference. So with that, what I thought I would do is try to at least describe a few of the concepts that are now emerging in the area of podocyte biology and glomerular biology in general. This is, as has been said by other speakers today and some of you, that, you know, we have to begin from fundamental knowledge before we can move to the clinic. We all really want to get the answer, but ultimately it's the ideas that are generated often in the laboratory that give us the insight to initiate different types of therapies. I think everybody here knows that ultimately you suffer through nephrotic syndrome the effects of the diseases of the glomerulus, the filter of the kidney. But ultimately we're most worried about losing our kidneys altogether, and we know that to lose one's kidneys is a really terrible thing to have happen. And this has all been said already. It's expensive for society. It's terrible for the patient. And life expectancy in general for a patient who loses one's kidneys is dramatically shortened. And, you know, from the foundation's perspective, I actually tell my medical students, you know, if you walk down the street and you tell your friend who comes across you in the street, I was just diagnosed with cancer, they would say to you, oh my God, what a terrible thing to have happen to you. You know, what is the doctor telling you? Are you going to survive? How long are you going to survive? It's the first thing that people think about. If a patient walks down the street, has just been diagnosed with kidney disease and has lost their kidneys, most lay people encountering that will say, well, it's a terrible thing, but, you know, so what? You know, what are the consequences? There's really a very poor understanding in the lay community, in the general community, about how serious these diseases really are. And I think this slide actually kind of summarizes in my mind, you know, that losing one's kidney is just like having the diagnosis of lung cancer. For an adult, a 50-year-old adult, it means that on average, all comers of all types of reasons for losing one's kidneys, the median survival is only 5 years. 50% of people die within 5 years of reaching end stage when you're 50 years old. For kids, even kids, there's a dramatic effect on survival. And I know what the composition of this crowd is, but I think it's important to recognize this and to try to make the world aware of this, because this is where the money comes from. And if the Congress understands how significant a problem this is, maybe you'll get what you really need. This has also kind of been said today, and that is that glomerular disease is, taken as a group, is the most common cause of end-stage kidney disease. we try to sell the importance of glomerular disease, and so we say, well, if you look at all the causes of glomerular disease, diabetes being the #1 cause, hypertension the second most important cause, and glomerulopathy is similar to FSGS being the third most common cause, 75% of all end-stage kidney disease is caused by glomerular disease. So we think it's a very important problem. What I'd like to do is, this has also been introduced to you today, but I'd like to kind of go over this in a little bit more detail because I'm going to be talking about biology here, and I want you to understand the concepts as we move through it. And please stop me. If I don't make something clear, stop me and I'll try to clarify what I'm saying. So you've been introduced to the glomerulus, the filter of the kidney. Structurally, there is an outer capsule to the glomerulus, which really contains a space that is where the initial urine is formed. And this urine is really an ultrafiltrate of serum. It's really the fluid of the blood vessels that kind of moves across the filter barrier into this space, which is called Bowman space. And that early urine moves through the nephron, and it's in the nephron that it gets processed. Okay, so the filter is really just a filter, and then everything else that happens to urine before it kind of comes out through the bladder and into the outside world goes on in the nephron. And by electron microscopy, this is what this thing looks like. It's this really tuft of capillaries, little tiny blood vessels, that are surrounded by a specialized cell, which I'm going to talk to you about, and then this potential space where the primary urine is formed, and then it moves into the tubule. And we're going to focus now on one part of the filter capillary, and that's within this yellow box. And schematically, it looks something like this. So there's a chunk of a capillary loop, small blood vessel. It's actually a very specialized blood vessel in that it has holes in it, which we call fenestrae. And then there are actually two more layers to the filter apparatus. There's a basement membrane, or a kind of a proteinaceous mix of things that surrounds the capillary. And then there's the specialized epithelial cell, which we call the podocyte. And the podocyte is this kind of very amazing cell we truly don't know all that much about right now. But it has the shape of an octopus. It has a primary cell body and then primary processes, and then these processes kind of subdivide into these finger-like things that kind of interdigitate and wrap around the capillaries of the glomerular filter. So this is a kind of a three-dimensional picture. In 2 dimensions, if you were to cut through a capillary, this is what it looks like. And again, just to emphasize, there's the capillary lumen, the center part of the blood vessel. There's the endothelial cell, which makes up the wall of the capillary. And then there's the basement membrane layer, this kind of grayish line here. And on top of that, the podocyte, this really specialized epithelial cell, again, with the cell body, and then dividing up into these primary and secondary processes that wrap around the capillary itself. And again, by electron microscopy, the cell looks like this. So it's this very weird-looking cell in the body. And it's kind of interesting, as people have studied this in intensive detail in the last few years, people have started to equate the podocyte with a neuron, actually. And there are actually many similarities. And if you can think of actually the podocyte process as a neurite, those projections that move from the cell body of the neuron and move to different parts of the brain, or innervate your muscles and other parts of your body. So again, this has been talked about. The normal glomerular filter has several roles. One is to retain in the blood vessel blood cells and most proteins of the blood. And it's also important for readily filtering water and electrolytes, things like sodium and potassium, across its barrier, so that the kidney can then decide, basically, do I need this stuff that's been filtered, or can I get rid of it? The other thing that the filter filters are the metabolic toxins that are the normal byproduct of metabolism, of everyday life. And those are those uremic toxins that we worry about accumulating in the situation where the kidney is failing. And again, if the filter fails, then the signs of the sick filter are what you've been talking about today: proteinuria, edema, hypercholesterolemia, increased lipid production in the body, and low protein in the blood. And that occurs because the filter fails. It now allows small and medium-sized macromolecules that don't normally pass across the barrier to move into Bowman space, to move into the urinary space, and then eventually out of the body. So one of the key questions has been, for people who study the podocyte, is how is it that the filter really works? How does it really allow for this selective processing or the selective filtering that goes on there? The patient who presents with swelling, with a nephrotic syndrome, often, when they're an adult anyway, you get biopsied pretty regularly. When you're a child, obviously, therapy is first attempted, and when that fails, then the patient gets biopsied. We come up with a pathologic diagnosis, and then we possibly initiate therapy. And I'm going to focus a little bit on focal segmental glomerulosclerosis today, but only just to make a few points. The first is, and I've heard this said by every one of the speakers today, and this is a very important point, is that FSGS is not a disease. It's a description of what we see under the microscope. Okay? There are probably multiple diseases, meaning there are multiple reasons why one can get this segmental scarring occurring in the filter. And it's those individual disease processes that we really want to understand. What we're looking at here, again, is not a disease. It's the byproduct of the disease. And the byproduct of the disease, at least at the microscopic level, looks the same no matter what it is that's causing it. Okay? And that's a really important concept. And it's important because it influences how we should think about treatment and even studying treatment. Okay? So I don't know if Rick Haskell is still here. He's going to get mad at me for saying this. But one of the reasons why a podocyte biologist might be a little bit uncomfortable with a clinical trial in FSGS today is that when we take patients who are between 2 years old and 40 years old and lump them all together, we don't know what we're studying. We're studying what we see under the microscope rather than a particular disease. And one of the reasons that glomerular disease research, clinical research, has been problematic over the decades has been that we don't have a way yet of subdividing what is the specific biological process that's producing the microscopic picture. And so when we treat a patient with Cellcept or Cytoxin or cyclosporin or prednisone, we don't know what disease we're treating. We're lumping together maybe 50 different diagnoses and treating them all the same. And when we get a variety of responses, then we don't know what to do with it because the statistics, somebody brought up statistics earlier today, the statistics are just a jumble and we're left with no conclusion. And that's the problem. And that's where we're at. And that's the state of the art. And what the NIH and Rick are doing is very important because maybe we will learn something that will help us, but maybe we won't. And we shouldn't be too discouraged if we don't get a positive result out of that trial because, as Rick said, we're also going to learn a whole lot of other things that almost certainly will be helpful in better understanding the underlying biology so that we can then design more rational clinical